Hi, my name is Doneen Grimm, and I am the Medication Safety and Utilization Manager at St. Joseph's Hospital and Medical Center in Phoenix, Arizona. Wow, what a great presentation so far. If you are here for the first three parts, you have learned that while the United States of America is 4% of the world's population, we consume 90% of the world's opioids. We also account for 27% of the world's opioids deaths. The chances of chronic use increase after just 3 days of therapy and continue to rise rapidly thereafter. There's definitely unintended effects of opioids, and there's alternatives that we can be using. There's also multimodal pain management. So now we are going to switch gears, and we're really going to talk about opioid prescribing in Arizona and Nebraska. So this data is from 2019, and you can see in Arizona, there was 21 to 57 deaths per 100,000 people population. In Nebraska, it was 6.9 to 11. The number of deaths in Arizona in 2009 due to opioids was 1,907 compared to 161 in Nebraska. And overall in the world, there was over 76,000. And this makes the news. We're going to talk about what you should know, whether it's laws, rules, regulatory, what you need to know to protect yourself and your license. So in this example here from April 2021, there were 60 people in 8 states that faced criminal charges for illegally prescribing and distributing opioids in the United States. And this was brought forward by the Department of Justice. In another case in Tennessee, there was actually 60 Medicare or medical professionals that were charged for illegally prescribing opioids to their patients without proper monitoring. A couple other cases in Alabama, there was a provider that was allegedly prescribed opioids in high doses and in dangerous combination, knowing that the patients had already failed drug screens and that they were addicts. They were also charged. We had one provider that was charging a concierge fee to his friends on Facebook, and it was determined that he prescribed approximately 500,000 oxycodone pills, 300,000 oxycodone pills, and over 1,500 fentanyl patches over a 3-year program. He was also prosecuted. This also is more local. If you go to your own medical boards, you'll see providers being sanctioned and their abilities revoked due to opioids. Just this Tuesday, I looked at the Arizona Medical Board, and there was one provider who they reviewed 4 patient cases. They deemed that he deviated from the standard of care in regards to the treatment of his patients. All 4 patients were prescribed high-dose opioids and benzodiazepines without clinical basis for the prescribing and without managing pain with other non-pharmacologic interventions. He prescribed early refills, and he failed to address the urinary drug screens. With this, the board decided that he was unprofessional, and he is now prohibited from dispensing controlled substances in the state of Arizona. So these are real cases. They can happen to you. And so that's why you need to be educated on your rules and regulations. So let's get started. So the first rule, continuing education. I think that's why we're all here today. So there is a statute in Nebraska as well as a Senate bill in Arizona that requires 3 hours of CME in opioid-related clinical education. In Arizona, it's required for any provider who has a DEA registration number, whether you use it or not. And in Nebraska, it's required upon relicensing. There's also prescription drug monitoring programs. So both of these were mandated for pharmacies in 2018. So retail pharmacies do have to report this data, and then it loads into their prescription monitoring programs. Now in Arizona, a provider is mandated to open up, launch the PMP, and review the patient's profile before prescribing any opioids at all. So before you order or prescribe any opioids, you do need to launch this and look to see what the patient's received. You may be asking, what's the difference between prescribing and ordering? Well, in Arizona, prescribing is outpatient. You prescribe for your patient. While ordering is what we do while we're in the hospital. We order medications for our patients. In Arizona, there's a couple exceptions. So any patient with an end-of-life condition or pain associated with active malignancy would be an exception. Also, if you're just changing the drug or the dose due to an adverse drug reaction within the first 72 hours, you do not need to relaunch it. If you're ordering, so if the patient's in the hospital and you're ordering an opioid for no longer than 3 calendar days, and also if you're ordering the medication for a surgical or other invasive procedure. In Nebraska, there's no mandate to launch this. It is available for healthcare professionals. And really, we think it's best practice. So whether you're an exception or you don't have to launch the PMP, we highly encourage it as a best practice. Okay, what about discussions with patients? We're going to prescribe or order an opioid for our patients. What do we have to discuss? Well, according to the Department of Health Services in Arizona, you must actually obtain informed consent from the patient or the patient's representative before any opioid is prescribed or ordered. With other informed consents, you really need to talk about the risks, benefits, and alternatives. You need to allow the patient an opportunity to ask any questions, and this needs to be a signed document. The exceptions are the same as they were with the education. And then in Nebraska, their statute outlines information that must be discussed to that same patient or guardian before prescribing any Control 2 medications. You need to discuss the risks and addictions, as well as overdose. You need to talk about the reasons why the prescription is necessary and any alternatives that may be available. Once again, for Nebraska, the 2 exclusions are hospice and if the course of treatment is for cancer or palliative care patients. Please make sure this is well documented in your medical charts for your patients. Okay, limitations. So I broke these out into Arizona and Nebraska since they are quite different. So in Arizona, really our limitations apply only to opioid naive patients, all opioid naive patients. At the bottom of the slide, you can see the definition of an opioid naive patient is a patient who's had no Schedule II controlled medications in the past 60 days, as evident by the controlled substance PMP. So if you launch that PMP and you see that they got Oxy 59 days ago, they are not opioid naive. If they got that same Oxy prescription filled 61 days ago, they would be naive. If your patient is naive, the initial prescription for the Control 2 can be no more than 5 days. If they did have a surgical procedure, you can go up to 14 days. So it doesn't matter how much opioids they received in the hospital, since that does not result out in the PMP, you need to stick to these guidelines. Also, these guidelines are a maximum. If you had a surgical patient and you don't think they need 14 days, you are definitely in your right to prescribe less, and that's also encouraged. The exceptions are on the right-hand side of the page. There's also limits into the milligrams that you can prescribe each day. So you cannot prescribe more than 90 morphine milliequivalents daily dose. If by chance you do prescribe a new prescription and it is above that 90 morphine milliequivalents, you need to consult with a physician who is board certified in pain. In Nebraska, your limitations are really due to your Medicaid program as well as to children. So if you have a patient who's part of the Medicaid program and they're opioid naive, and that definition is slightly different than Arizona. So here, an opioid naive patient has a 90-day claims history for evidence of prior opioid use. So once again, at day 91, they're naive. At day 89, they're okay. So if you have that same opioid naive patient, they're limited to a 7-day supply of medication and a maximum dosage of 50 morphine milliequivalents per day. For children, so younger than 18, for outpatient acute condition, no more than 7 days. There are exceptions for these children. If it's associated with cancer diagnosis or palliative care, you can prescribe greater than 7 days, but you really need to make sure you're documenting the condition and why you're exceeding that 7-day limit. There's also a second limitation in Nebraska, and that has to do with the Medicare program. For any patient who's on the Medicare program, you are limited to prescribing a quantity of a short-acting opioid to 150 tablets or capsules per rolling 30 days. If you need to prescribe more than 120 milliequivalents per day, you need to make sure you're documenting a weaning strategy in that medical record. Also want to emphasize, these are the maximums. We really want you to do your best job and use your judgment for the appropriate amount for your patients, but really you should not be exceeding these maximums. Naloxone. There are rules about prescribing naloxone. In Arizona, it states that if you do issue that new prescription for above 90 morphine milliequivalents per day, whether they're naive or not, you need to also prescribe naloxone or another opioid antagonist. So when you're handing them that prescription, please make sure you also are handing them a prescription for naloxone. Nebraska takes a very different stance. It's really about protecting the provider for a patient that they come across that may not be your own patient, but a person who's just experienced an opioid-related overdose, or if a family member or a friend or another person in a position to assist a person with an opioid-related overdose comes to you, or emergency responder. So if any of those people come to you and ask you for a prescription, if you are acting with reasonable care, you may prescribe, administer, or dispense naloxone without being subject to any administrative action or criminal prosecution. Okay, e-prescribing. So in Arizona, it's mandated. As of January 1st, 2020, any prescription for controlled level 2 must be electronically transmitted to a dispensing pharmacy in Arizona. Of course, if there's a downtime, that's an exception and you can write that on the prescription. But really, besides the downtime that you cannot prescribe or e-prescribe that medication, you need to be e-prescribing. In Nebraska, there is no mandate. You can choose to e-prescribe if you'd like to. They do believe that this reduces burden. It may improve workflow and productivity, and it definitely increases safety and security. So once again, this would be one of those things that we consider a best practice, but in the state of Nebraska, there is no mandate. That concludes my presentation. Please, if there's any questions, don't hesitate to reach out to me. I'm available to answer any questions. Also, the State Medical Board, as well as the State Board of Pharmacy, those are great resources to launch if you want to look to see updates to the laws. These things do change periodically, and all that information can also be found there. Once again, thank you for listening to my presentation. Hope you have a great rest of your day.